Hey, this is Jason the PT, and if you're dealing with weakness in your orthopedic care, I think we need to talk about it. There's some things here that you might be missing, and I'd like to clear it up for you. So, this is Around the Treatment Table with Jason the PT. All right, everybody, I am back. I took an extended hiatus, just being pretty time impoverished, and it's a busy job saving the world one knee at a time. But I've had a few patients that have been really interested in my explanations about muscle weakness and its role in outpatient orthopedic physical therapy. And they wanted me to talk about it, so I am back talking about muscle weakness. Um, Muscle weakness in orthopedic physical therapy is probably like the number one reason people are given for why they have what they have. And on its face, it would make sense. I mean, like you have weakness and you have this problem. Um, but the explanations of why people are weak and the role of that weakness, I think, doesn't work very well. You know, you have somebody come in from the gym, for example, and they can deadlift 300 pounds. Now they're having this knee problem or whatever, and they identify, weakness. And it's like, okay, dude or dudette can deadlift 300 pounds. Like, how would they possibly have weakness, right? Um, that logic doesn't make sense. Nor does it really make sense when you're looking at the context of what people do. All right, let's not take a gym rat. Let's just take somebody 55 years old. They walk the dog a couple times a day, and that's the extent of their problem. And then all of a sudden, now they're having knee problems. They go to physical therapy, and they're told their glutes on that side are weak. And on its face, that might make sense. There's weakness, you have to deal with the weakness. So we jump into the rehab. But what we don't do really is explain how the weakness came about. Now, okay, this person may not necessarily be the most active in the world, but most people, the last time I checked, conditioned to whatever walk of life that they're in, right? So if you're walking the dog a couple times a day and that's all you're really doing, and you're not asking for the world, then how all of a sudden did you go backwards? As long as you're staying in your bell curve of activities, generally, people just don't randomly go backwards. So, and it's really not how the body works. I mean, you know, mysterious muscle weakness, I kind of have a problem with that. Because muscle weakness, especially when it's mysterious, would be cause for a medical problem. Now, of course, then you'd be checking people for strokes and stuff like that, but obviously the patient's coming in the clinic and they're not having a stroke. So what is that weakness? Where did that weakness come from? And is it a cause of the problem, or is it a downstream effect of the problem? And so that's what I really want to clear up today. So first and foremost, it's probably the best to understand what a muscle contraction is. And most people think it's really just the capacity of that muscle to be able to generate power. And there is a part of that. So the muscle, really though, that muscle contraction is much more complex. I mean, there are many other things that contribute to the muscle contraction, and it really isn't just a point A to B. It really is more of a feedback loop, and that's what we learn in neuroscience and physical therapy. Um, you learn how a muscle contraction comes about. Now, without getting too far into the weeds, so I start losing people, but a muscle contraction is really an end result of a complex equation. Your brain, you have to come up with the idea that you're going to move. Your brain comes up with a plan for that, but it takes in information from your periphery, your arms, legs, all of that stuff, your joints, about where you are in space. So it can start saying, okay, this is where I am. Your brain says, okay, this is where we need to go, and this is what I'm going to send out to those muscles to make that happen. So a signal is then sent out to the muscles, and then the muscles will start to contract. And then as that motion is being carried out, there's a continuous feedback loop. Okay. Your brain is constantly reevaluating where you are and error correcting. And you might actually see that with somebody with Parkinson's. You watch them do a nose to finger test, and they do this. That's very poor error correction. Your brain is doing something similar, but it's really good at it. So that motion looks smooth, but there is a constant error correction. But the point I'm trying to make with all of this is that the muscles really are just the end result of that process. How those muscles contract is an end result. You need to have a neurological system that's capable of receiving and sending information, in order to plan, but then also to send instructions. And then you have to have the joints, which act as sensors, that muscle can act around in order to be successful. So from a muscle contraction standpoint, it's much more complicated than just the capacity. The capacity means, okay, you can move more than say somebody else that isn't as strong, but it isn't like the thing. Like it isn't just an end result. There is that feedback loop. So it's more complex than just saying the muscle. But it's very easy to look at the muscle and say you're weak and I need to strengthen you. But there's more to it. Human beings are the most complex machine on the planet. So getting that idea that it's a feedback loop versus just a capacity problem, I think is really important. Secondly, I think it's really important also to understand the body tissue we're talking about, muscles. And in the grand scheme of things, muscles really are some of the most adaptable and best healing tissues that we have. So when you're looking at different body tissues, like cartilage, for example, doesn't have a great healing capacity and it's not adaptable, which is why cartilage problems don't heal very well. But most people go to the gym, they get sore 24, 36 hours later, they're better. I mean, they really are built for abuse. And if you're going to the gym and you're being constructive in the gym, like you're not doing crazy stuff, then, the muscles will adapt and you get stronger. So when a patient comes in and they're having a problem and they're really not doing anything nuts, they're just living their lives and nothing really changed, then how would weakness come about? They should have adapted to what they're doing. And then if the muscle is even part of the problem and there's pain there, and there can be, and there's a reason for it, why did it go backwards? Like the human body doesn't do that. Muscles don't just on their own decide, I'm done. Like that's not a thing, but we're talking about blaming some of the best healing and most adaptable tissues, which doesn't seem to make sense, and that's one of those things. Like I get it on its face and it draws a very nice line from point A to point B about what's causing it, but it doesn't work physiologically when you really kind of get behind what a muscle is and how it functions. It just doesn't jive. When you see somebody that's had a stroke, okay, it's understood there was a problem with the brain and the muscle problem is a result of that. So I have a hard time. You couldn't make it fly to be like, well, if you just strengthened those muscles, you wouldn't have had that problem. Like that's understood and that's a gimme. And the people that don't quite believe in this want to put like a stroke and say, well, that's a stroke. We're obviously not dealing with stroke, but that's an extreme example. And it is. That's what happens when the brain goes kablooey. My argument was these things exist on a continuum. There's really no black or white. So when you're looking at a muscle contraction or a problematic muscle, whether it's weak or becoming painful, it's important to understand that there's nerves behind that. And nerves are not to be trifled with. They don't do very well when they're being antagonized. If you don't believe me, flick your funny bone and tell me what you get. You're going to get all sorts of sensory changes. And that's just with you doing this, right? So it's important to understand that the more sensitive system behind the muscle contraction would be the neurological system, taking in information and taking that out. And if that's wrong, or you're getting some bad input, or you're messing with the output, that's going to affect your muscle contraction. Is it as clear as a stroke? It's not. But there are mechanisms and there are names for these problems that, I think people need to know about. Because if you're not understanding why you're weak to begin with, and you're just doing the rehab, you're not really getting to the problem. So my argument would be weakness is more neurological in origin than it is a capacity problem. I'm not saying there isn't a capacity problem. Obviously the muscle is weak, but it's in relationship to the neurological system and the signals that it's getting. That will create a change in muscle contraction. So what are we talking about when we have muscle problems? And there are different types. So the first type is probably the easiest for people to understand because most folks may have an example they can think back to. But let's take an ACL tear. Out on the field playing football, somebody gets chop blocked and it tears the ACL. That will create a very large inflammatory process within the joint. Immediately, the person that's dealing with this problem is not going to be able to access their quadricep muscles or any muscle that crosses this joint. The pain and the inflammation are caustic to nerves, and it's going to alter that signal. It's going to change the brain's ability to receive information from the joint and from the muscles, because the inflammation inhibits that signal. Conversely, the brain then doesn't have a great plan for this, and it's going to have a hard time sending that signal back down. So therefore, it's going to be weakness, and the person on the field, they can't access it. They're going to have to be carried off the field. But that's why those muscles can't contract. Now again, extreme example, but I think we see things better in the extremes. On the other end of the spectrum, okay, now you're talking about, okay, no major trauma, but now we have some muscle weakness. What will happen is any sort of aberrant input over a longer period of time, maybe it's a minor arthritis or it's a joint that's not gliding very well, it starts to mess up those signals. So now it's not this big aha, it's this lower load, longer duration aberrant input going into the system, which then creates basically a bad feedback loop. And this is called arthrogenic inhibition. Basically, the joint itself and its ability to send signals back to the brain is being inhibited because of that aberrant input. And its hallmark is timing issues. This actually you can see with anybody that has a grandma or grandparent, whoever, that has some arthritis. They'll talk about their knee buckling. That's arthrogenic inhibition. We know they have some cartilaginous changes in the knee, there's some inflammation, bad input getting into the system, the brain gets whatever it gets and sends out a signal back to the muscles to control the joint. But that signal is not clear, and it creates a timing problem. So the person goes to put the leg down, but the muscles didn't get the signal to kick in, all of a sudden the knee gives out. And that's a knee buckling. That's a classic example of arthrogenic inhibition, also called reflex inhibition for you science buffs out there. But that's arthrogenic inhibition. Again, another somewhat extreme example, but it exists on a continuum. So let's say you have an athlete that's working at a higher level and timing is much more important. What will happen is if there's any aberrant input, pain or inflammation, any of that, even at a low level, maybe it nags you a little bit every so often, that's altering nerve signals, and you need those nerve signals much, much more when you're talking about speed and force recycling, especially when you're doing agility work. So you have to be able to control the inflammation and look at the bad joint mechanics that are likely being caused, or anything that's feeding into that joint problem, especially in the lower extremity. Okay. The second type of weakness, and again, we learn about this in physical therapy school, but I don't think it's applied very well. I happened to go to a school that was very neuro-based. So when I looked at weakness, most of my classmates went into stroke, traumatic brain injury, spinal cord. And spinal cord is actually a very good example. But weakness to me was always had a neurological origin. Orthopedics wasn't as big of a thing. But what we learn in physical therapy school, and what you probably can understand, just from a basic knowledge, is that every level of the spine has key muscles that it goes to, okay? And those are called myotomes. So if you're looking at the myotome chart, what you're going to find, and I'm going to go through this, kind of grossly, but if you have a problem at L3, which is a little bit higher up in the lumbar spine, that basically feeds your quadriceps. When you start getting down to L4, you're looking at some of the ankle muscles. L5 goes down into the foot, a little bit of the glutes. S1, which is the top of your tailbone, is the bigger feeder for the gluteal muscles. Okay, so let's take a spinal cord injury. Let's say you have a problem at L5. You're pretty much going to lose stuff below the knee, but you're going to retain what you have at L3. So your quadriceps can still work, and you may be able to walk, with some bracing. So again, extreme example, but we see things better in the extremes. On the opposite end of the spectrum, I think you can have some aberrant input going on at the lumbar spine, jammed joint, maybe a little bit of disc discomfort. Most people that are telling me they have problems in the lower extremities also have a low level back pain or have had a history of back pain. Okay. And I think what happens there, and this is what we call segmental facilitation, that at that spinal level, you have the nerves that exit. Well, any sort of pain, inflammation, or aberrant input going on at that level is going to affect that nerve's ability to send muscles signals and take in information. Okay, so whereas arthrogenic inhibition, any muscle that crosses that joint and depends on its input will be affected, and the muscles, typically will cross that joint. With segmental facilitation, it's any muscle that's connected to that nerve. Okay, so let me put a little bit more context. Like, people will talk about gluteal muscle weakness. Okay, and that's a thing, and the weakness is real, but where is it coming from? Well, if that patient is having some low level amounts of low back pain or some sacroiliac joint dysfunction, it's going to affect S1 and maybe even L5. And they'll talk about gluteal muscle weakness. And then the next question I ask is, what about your anterior tibialis muscles, the muscles that sit at the front of the shin on that same side? Do you ever get any sort of like weird muscular symptoms, there? And like, yeah, sometimes when I'm walking, I feel like those muscles fatigue out really quickly. Guess what? That's L5. So now you have two muscles that are seemingly unrelated other than the fact that they're connected to the same nerve. And then I ask about back pain. Yeah, I get a little bit of discomfort here and there. Again, nerves are very sensitive things. They don't like the inflammation. They don't like pain. All of that ends up being inhibitory. If you're inhibiting that signal down to those muscles, guess what? Weakness. That's where weakness comes from. But the point is you got to read the tea leaves a little bit of this. So here's an example, and glutes are a perfect example, and it's a combo. Okay, so what I'll notice with people that have gluteal muscle weakness, right? There's typically a lack of hip internal rotation and extension because those are coupled motions, and that jamming of the joint creates arthrogenic inhibition. So now those gluteal muscles that are crossing that joint are becoming inhibited. Now, what's interesting is because the hip is very important as it pertains to the lumbopelvic mechanics, if the hip can't fully extend, the spine overextends. That will start to create increased compression at your facet joints, usually at L5 and S1, which also happens to be the main feeders for your gluteal muscles. So those glutes are getting double dipped on. But again, it's not the muscle's capacity that is the driver of the problem. The lack of capacity is due to the neurological side behind it. So how does this get remedied? You find the joints that are not behaving the way that they should, and you do some joint mobilizations. You allow better signals to travel up and down so your muscles can get a clearer picture. If you're having a problem at the spine, you do manual therapy, whether that's joint mobilizations at the spine, spinal manipulation. And what happens, and I've done this, I'll test their weakness, okay, and the glutes are weak. I do some hip mobilizations, sacroiliac joint mobilization, and a lumbar spine manipulation. All the things that could cause that muscle to get weak. And then I test them again, and they're stronger. That's because it's not a problem of capacity. It's a problem of voltage. You're not sending enough volts to push the muscles to get the contraction that you want. Yes, with a lack of nerve signal over time at the muscle level, the muscle can weaken. But by doing these things, you are now sending better voltage out to the muscles to make the rehab side better. But this is why people generally don't get stronger meaningfully. I have patients that go other places, they're told they have weak glutes and they jump right into the exercises, which again, psychologically makes sense. But at the end of the day, we haven't understood the weakness. So the exercises are not as efficient as they could be in terms of the rehab. Because again, it's a power problem to the muscles, not the muscle itself. Now, yes, doing exercises can help alter and improve nerve signals. That is absolutely true. But if it's being inhibited because of bad joint mechanics and bad aberrant input coming in at the spine, you have to address those things, allow a signal to get there. So I'll do the manual therapy side, and patients are like, oh, I'm stronger. And yeah, I can see that. I'm like, well, what do you do now? What do I do now? I'm like, do the exercises they told you. And they come back next visit and like, I'm so sore. I go, yeah, you're actually getting those muscle fibers that you weren't able to reach. You weren't pushing enough voltage in order to get all of those muscles fibers to fire. And the fibers you were using were being overused. So the idea is if you're not pushing enough electricity, and let's say you only had 4 muscle fibers that were working, obviously there's millions, but let's just say you have 4 muscle fibers that need to power your glute, that work on your glutes, but you're only pushing enough voltage for 2, Okay, yeah, you might be able to, muster a fair amount of strength to do what you're going to do, but you're asking two fibers to do the work of four. So that means the two that are working are overworking and they will break down faster. Then all of a sudden, now you're starting to have muscle problems, trigger points, tendon issues, things like that. So that lack of neurological input to distribute load over a larger area is gone. What is left does the work, and then that starts to break down. The big takeaway, though, is that you have to understand that muscle contractions are very complex. It's more than just a capacity problem. Two, when you look at the body tissues like muscles, you're dealing with some of the best adapting and best healing tissues we have. So it makes a really difficult case to say they just up and decided to go south for no reason, absent of anything else stark. So then you have to go look for reasons for weakness. And you should be looking at the joint mechanics and addressing those. And then you should go address the spinal level that powers that. And like I said, every level of the spine has key muscles it goes to. But that is your weakness. It's neurologically driven. It's not a problem of capacity. If it was a problem of just capacity, you could just do the exercises and that would be the end of it. But patients often will do their exercises and maybe they get middling results or they get a little bit better and then it comes back. You know, you should be adapting and conditioning, not going the wrong way. And if you're doing the exercises and not getting what you want out of it or feeling you constantly have to do it just to maintain, the muscle probably is not the problem. It is another end result of the problem. And we need to address it as such because you can't blame these tissues reasonably and may have it make sense. It just doesn't make sense to me. But that's the intricacies of a muscle contraction and where they go. It's a downstream effect, and that is marrying up the neurological side and the orthopedic side, and that has to all work together. So, yeah, muscle weakness, it's a thing. Exercises are great. They're just misplaced. You have to go look at the reasons for weakness because that's one big black hole we just glaze over. And I don't think we do that very well in PT. We just get to the doing and we feel better doing, but there's another layer there. So yeah, muscle weakness. It's a thing. Anyway, that's my time. Thanks for welcoming me back. And I'll be on more frequently and talking about more things with physical therapy. So thank you very much, and I'll see you at the next episode.